Oh, hey, Chris.
Hey Chuck, how are you?
I'm well. It's Saturday morning talking to you. It's a beautiful day out there.
So instead of being outside, we're both inside on Zoom talking to each other. That's great.
Yeah, it'd be better if we were at the pool having a chat outside. I agree. That might be preferable.
I will be at the pool shortly after this. So I'm very excited to go outside. Had a fun night making pizzas yesterday. That's kind of our new thing in the family. My daughter is amazing at making pizza dough. And she crushes it. My one of the reasons why I didn't get into the pizza oven as much recently is I struggled with the dough because I don't bake. And she has perfected it, which is amazing. An 8-year-old has perfected dough, which is awesome.
So, do you have a pizza oven, or how does that work?
Yeah, we have a pizza oven. Got it. My outdoor kitchen is very crowded right now because it was not designed to be an outdoor kitchen space, but it's got a gas grill, a pizza oven, and a vertical smoker, a pellet smoker. So it's just a fun spot. Gets a lot of traffic. But yeah, the pizza oven's kind of the last thing that would fit in there.
Oh my gosh, that is kind of awesome. So, you guys are doing that every weekend?
It's 2 weekends in a row, so I guess it's every weekend. But yes, so we're enjoying that. Anyway, today we're gonna have a good
Wait, wait, wait,
conversation.
wait. I
Hey,
have
hey,
more to say.
people don't want to hear us, chop it up too much.
Well, well, that's fine. Then I'll pass. I do have to say one
No,
cool.
say
I
what you
have
wanted to say.
I have to say one cool thing. Have I told you about my latest pool purchase?
I think you mentioned it at the end of the last podcast. Perhaps maybe this goes into the AI conversation, but did you get the robotic thing, the skimmer?
I have the solar powered pool skimmer is the greatest thing ever. It is life changing. Not about the work of skimming the pool, but just it creates a beautiful pool. It works seamlessly. It's not a robot, so it's not going on the bottom. Anyways, for someone who just doesn't like their pool very much, it gives me joy.
What is the name of the company that makes this
I
device?
don't know, but I think
Because they can sponsor the podcast. Because you clearly just gave them a shout out before any either of our two sponsors.
well, the other thing I was going to say is when I visited Cedar Sinai a few years ago for graduation, Eugene Tsai makes and it has an incredible outdoor pizza kitchen and makes an amazing pizza. And that was really enjoyable in Southern California, sitting outside,
Yeah.
talking.
That's got to be lovely. That's got to be lovely. I was recently in Los Angeles for a wedding, and it was, weather was beautiful, going for a run, on the Santa Monica beach. It was awesome. Then I sat in traffic forever. It took us 2 hours to get to the place for the wedding, and it took us 20 minutes to get home. So it's just insane.
Yeah, there's trade-offs everywhere.
Yeah.
There are, but you know what I want to hear about? I want to hear about the WashU Nerve meeting.
Yeah, so we had the Nerve meeting recently, and it was a pretty incredible experience. Had people coming in from 9 countries. It was a pretty packed room. Faculty came in. The cool part about the faculty, it's that it's everybody has had ties to WashU, either current faculty or former fellows or residents. So we had a really strong showing from our orthopedic team as well as our plastic surgery colleagues in terms of great faculty. We switched up the format so it was more engaging with more debates and panels and cases as opposed to just lectures. And then the lab was always fun. And currently, some of our students are going to start looking at editing the videos that were taken in the lab. So we'll have an educational resource. I'm not sure how we're going to disseminate that just yet, but so it was a great course. Took a lot of energy. Really appreciate our sponsors that helped us with the course. So Checkpoint, Axygen, BioCircuit, and OrthoCell were the major sponsors. But people ask when we're doing it again. I don't know when, but I'm sure it'll happen at some point.
Gotcha. Well, congrats, and it looked like a great, great experience. Speaking of sponsors, the Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource.
Becoming a physician is hard. Finding the right job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand. And PracticeLink also provided some tickets for Cardinals game, which was really cool at the end of the course, kind of an impromptu thing. We invited our visitors from other countries. So some Costa Ricans and Brazilians and Panamanians went to a Cardinals game with our fellow Nick, excuse me, our fellow Travis, who's a plastic surgery fellow who hosted everybody. and Fraser Leversedge. And it was Travis and Fraser are Canadian. So basically, it was an international meeting at a Cardinals game, which was cool.
I love that. That's amazing. That is amazing.
I
All
tried to get
right.
them to do the 999 challenge, but they wouldn't do it. They couldn't commit.
I don't know what that is.
That's 9 beers, 9 hot dogs in 9 innings.
Oh God, it sounds horrible.
It sounds awful, but some people have tried. I've not endeavored that yet. I think that I would not be happy with it, the decision afterwards. Maybe
I'm not
10,
sure.
15 years ago I would be able to do it, but
Yeah, I think if it was 9 hot dogs, 9 beers, and 9 days, I might not make it.
So today we're going to go through what's new in hand surgery. So this was published earlier this year in JBJS, but we've had so many other fun things to talk about that we haven't gotten to it yet. Having edited this for 3 years in a row before, it's quite a bit of work. So shout out to Eric Wagner and Nina Sue from Emory for their efforts in doing this.
Yeah, I enjoy reading this. It's nice because it just exposes me to some things that I haven't seen, that we haven't seen, and that's really our goal with this conversation. Is just to hit some highlights. Hopefully, it's fodder for discussion, and that's what we'll do. We'll mention some of the articles and talk about our approach to some of these issues, which begins with artificial intelligence. It's I just think any conversation about the role of AI in medicine should really start with open evidence. I know it's not the point of this, but open evidence as an app or on your computer is an incredible resource that is changing the way many physicians, and some would say over 50% of physicians, access open evidence on a weekly basis. That is astounding. So that to me is the real AI paradigm shift for orthopedic surgery and physicians everywhere. But this conversation in this article is different.
Yeah, and actually, based on our episode that we had with Dr. Strelzo, I felt that I needed to learn more and use more AI. So I've been using AI for kind of day-to-day things, as well as when I was preparing my talks for the WashU Nerve course. So I used open evidence. I actually used our Ask WashU, which is the LLM that WashU has, and it was very good. It was not great. It was very good, but it was helpful. I think that it did require the quality of the prompt truly does matter. And we're seeing some of this, evidence, literature kind of creep into we use a bridge, and it is interesting to see the questions that are prompted by a bridge after patient interactions in terms of providing evidence. Um, so I don't know if you've used any of those, evidence prompts yet in a bridge, but it, it it makes you realize there's a huge opportunity here.
Yeah, there's a huge opportunity. And just to make sure we're all on the same page for listeners, Chris is referencing a Bridge AI, which is one of the ambient listening programs. And what you're seeing with all of these ambient listening programs is they're going beyond simply voice transcription to offering clinical assist, offer coding, things like that to differentiate themselves. And so some of them, there are partnerships which have developed with the New England Journal, with JAMA, et cetera. There's opportunities to use your previous notes. There's things that if you just keep doing what you've been doing, you'll miss out on some of the opportunities with these programs. So yes, trying to do all of that.
Yeah, and
I
I
think
took sorry to interrupt you. Go ahead.
no, please.
I was gonna say I took a screenshot of one of the decision support things that it provided, and I was seeing a patient post-op after doing a sciatic neurolysis with one of our sports partners who was doing a proximal hamstring. And I was seeing them, and we were talking about, I was doing my assessment of whether they had, calf pain to make sure they didn't have a DVT, et cetera. And the questions that came up were, what are the management options for post-operative neuropathic calf pain, indicators that warrant urgent repeat venous duplex, because I already sent the patient for a duplex before. So it's cool. Like, it makes you realize, like, there's just a lot of ways. Of course, I didn't have time to click on them because I had to go see the next patient.
That's
But
right.
so,
So
go ahead.
well, I was going to say the that I've been involved with the robotics platform in orthopedics, and that's hip and knee, now shoulder, as well as other specialties. And so I'm aware of what's out there for hand and wrist, but that is what Eric and Nina profiled first. The article by Yi et al. Looking at robotic assisted scaphoid fracture guide wire placement. And they found, the report is that they're 97% successful, and that all the fractures healed, meaning 97% of the time the robot placed the guide wire um, at the best point to start, meaning less fiddle factor.
On the first
Interesting
attempt.
on the first attempt, which is great. I think like many of the robotic assistants. For surgical interventions. Experienced clinicians can meet that, but it offers something different as people are on the learning curve. One could then argue, if you use the robot, do you ever advance on the learning curve? The answer is probably not. So, but it's a really interesting use of robotics for our world, which has been lacking thus far.
Yeah, no, I don't know if I had thought about an appropriate use of robotics in hand and wrist, but this is a really good one. I think that robotics might have a role in terms of things like, like you're fixing a distal radius, and maybe you're trying to make sure you're not in the joint with your screws, screw length. I think there's certainly a role for that. It's just a matter, it's a slippery slope of, when we start introducing more of this technology, how are we going to teach other, future people how to do it if they don't have the robot? It's like nobody knows how to do an open appendectomy anymore, perhaps because everybody's doing lap appies. So, maybe there is an appropriate place for this, but it'd be interesting to see how it evolves.
Yeah, and we're not going to lead the space, obviously. In hip and knee arthroplasty, maybe that's the leading area for orthopedics and understanding the implications for training. But really interesting conversation. The other articles mentioned, honestly, just aren't that exciting to me. It's about using AI to assist in the diagnosis of distal radius fractures, scaphoid fractures, use in DEXA. I don't know if any of those you want to highlight, but they're interesting, and it's certainly these are the right studies to be doing to advance our knowledge. I don't think they practically help us today.
I think maybe there's a role for, there's so many urgent cares that, people leave without a consistent diagnosis and appropriate treatment, that maybe there's a role for a non-specialist to use these tools, which I think certainly would help a lot in terms of, expediting patient care and avoiding unnecessary immobilization, et cetera. But yeah, I agree with you. I think there's certainly a role for these LLMs in terms of patient education. And I think that we've done some work in that area too. But nothing else with regards to the AI section was standing out to me.
Yeah. So then we transition to scaphoid non-unions, with a discussion initially on vascularized bone flaps or vascularized bone grafts. And one study demonstrated a 98% union rate with the Palmer vascularized bone graft, which is a technique I've utilized a few times, but it's not part of my regular arsenal. Any experience or any thoughts on that technique?
Yeah, so I haven't done a vascularized. I think the only thing I've used on the volar side has been essentially a strut, kind of that modified Russet. But honestly, my frequency of treating non-unions is not high. Like I'll do a few a year, and if there's anything that's even remotely concerning for needing a free tissue, I'd send them over to our partners, David Bergen and David Wright, who have expertise in that area because they can have a better conversation about all the options with the patient.
Yeah, and our partners are using the free graph. So it was interesting to see this study, which used the volar graph versus the Zeidenberg, or the dorsal 1-2 intercompartmental supraretinacular vascularized bone graft, and both showed really good healing percentages. So it's a little bit of a step in a different direction, because I think the momentum has shifted towards these free grafts from the knee, and this is saying, look, you can get good results with local grafts.
Yeah, and I think that's been the case. I mean, these are waist fractures or waist non-unions, so probably not the ones where you're super, super concerned. But and again, you have to think about the reason why they had the surgery. Is it because the fracture was or the injury wasn't appropriately identified? Were they not appropriately treated? Did they have a surgery that failed? So I think there's a lot of context that matters with these.
Yeah, the next group of papers, or maybe it was a single paper, no, it was a couple papers, looked at arthroscopic treatment of scaphoid fracture non-unions, and advocates for the technique providing reliably good healing rates. Like many things, I think there is likely a role for this, and like many things, for me personally, it's not a high use option for a variety of reasons. I think advancing the use of technology like arthroscopy is great. For me, it has to be justified as a real tool that helps change the paradigm of treatment. And for me, it hasn't done that yet.
Yeah, I was asking whether you were ready to adopt this or not. They discuss one article in which they compare the order of, the sequence of the steps, whether you put the K wires in first and then put your bone graft, or put your bone graft in and then put the K wires in. Um, I was trying to do the bone graft before I put the wires in, but sometimes I forget. But it is harder to put the bone graft where you want it with your wires, or you don't want to change your wires.
Yeah, that's right. I usually stabilize the fracture and then add my bone graft, depending, obviously, it's affected by what approach you're using, et cetera, et cetera. But from a volar approach, I usually try to get my scaphoid where I want it, especially if I'm using a screw to hold my positioning.
So they talk a little bit about MFTs, medial trochlear flaps here, but then they also talked about an alternative of using a proximal hamate non-vascularized autograft and having the volar capitohamate ligament for SL reconstruction. Is that something you're familiar with? I had not heard of that. I actually think it's kind of interesting.
It's very interesting. I have no familiarity with that. It is a interesting concept, and I love those who are innovative enough to come up with ideas like this. Um, you know, this was described by Cologne Murillo in the August Journal of Hand Surgery. Yeah, it's a novel concept and bears further exploration for sure.
So, the next section that they go through is about carpal instability. I had not really, I guess because we have so fortunate to have so many of us taking hand call that when I treat perilunates, I stick with the kind of the wagon wheel of pins to hold the carpus in place. I had not thought about using a dorsal spanning plate. What's been your experience with the wagon wheel of pins? It seems to work in my hands, but again, I don't do a ton of this.
Yeah, listen, there's no doubt that the pens seem to provide good results. I will sometimes skip the pens and use the internal brace option of securing the lunate to the scaphoid and lunate to tracheatrum. And I've been happy with that because I think it does the same thing and avoids the annoyance of the pens. Um,
In the acute setting.
in the acute setting, yes.
Oh, interesting.
Yeah.
Okay.
Yeah, it's a very simplistic technique, and it doesn't change my immobilization. And I want to give 6 weeks for healing of the capsular structures, et cetera. But it just removes the pins, and I've been really happy with that technique. So something to consider. Not trying to divert this conversation from the JBJS article to my personal preferences, but I do like that. And then, they pivot to talk about midcarpal instability and the open three ligament tenodesis and open dorsal capsulodesis being two options. I think that is absolutely true for both of those. However, it's interesting that this article didn't highlight arthroscopic techniques with heat shrinkage and limited open approaches. And presumably, Eric and Nina, given their arthroscopy focus, are using techniques like that, but there must not have been much new on those techniques to report.
Yeah, in the literature at least. Yeah, I'm pretty sure that, I don't see a lot of midcarpal instability. It may see me, but I may not have recognized it. So it's just not something that comes up very much for me. So they move on to talk about SL injuries. I still like the clenched fist view, but apparently it's not very sensitive. It's only 40% sensitivity in one of the articles that Nina and Eric cited here. I'm still gonna get it, but maybe it's not as reliable as I thought.
Yeah, it's a great point. I mean, I think part of it is how that clenched fist view is done. How standardized is it? Can you use a mini C-arm in your clinic and you look at dynamic clenched fist? I think all those play a role. But look, this is objective data that suggests we need to be careful with interpretation with isolated use of a clenched fist view.
So they got into an area that excites you, wrist arthroscopy, but there's no peds section, just so you know. There's no peds or congenital section. There's one citation about a peds plexus article. But so I'll let you lead the conversation about wrist arthroscopy.
Yeah, it's actually a pretty short discussion. And so there is. It starts with a discussion of Kienbach's disease, stages 2 to 3B, with arthroscopic cord decompression of the lunate, with improved outcomes at 3 years. Another study looked at perilunate injuries with arthroscopic surgery with improved outcome, and finally looking at arthroscopic intervention for TFCC tears. Um, there was a um, they cite our study.
You're
They
like, there was
cite
some article on this.
there was some crappy article. They cite our study on reliability of TFCC tear treatment with wrist arthroscopy, and we demonstrated poor interobserver reliability. And they cite another study showing that there can be good outcomes. So the bottom line, my perception of where we are with TFCC assessment and treatment is that I think we have a better understanding of what can happen to the TFCC, but having agreement amongst arthroscopists of what we're seeing and what the ideal treatment might be is lacking. And so that's where I hope we can move forward as an arthroscopy community.
You can take that entire statement you said and substitute our TFCC for brachial plexus, panplexus, and arthroscopy for nerve surgeons, and it's the exact same thing.
Oh, that's so interesting. I'm sure we could probably keep going with other areas in our discipline.
So, thumb CMC arthritis. So, I think that there's more articles demonstrating, a suture suspension or a suture tape suspension based on what you're doing have pretty similar outcomes to an LRTI, maybe faster return to work and activities. So numerous systematic reviews demonstrating that as well. But there's still, I think some concern about whether, the results from that are going to be as durable and even whether the LRTI is truly the gold standard here.
Yeah, what's happening, and I think our international colleagues might roll their eyes a little bit, but in the United States, it is only now that we're starting to see the appearance of the dual mobility CMC implant arthroplasty. And certainly there are institutions across the country who have good experience. And I think, it's personally it's coming to WashU, not in my hands, but I look forward to seeing some of the results. Historically, implant arthroplasty for CMC has not been a favorable outcome, but new implants and new technology seem to have elevated it. And the question will be, does it perform better than the gold standard, which for many remains the LRTI?
The bronze standard, perhaps. But it is going to be very, I mean, for a just as a category, implant arthroplasty had a rough go the last time it was in the States, but clearly things have changed. Like you said, technology and technique. From what I understand and from what I hear from people, the company that is working on this and pushing it through in the states as being very intentional with who they're allowing to use the technique and use the implant, and they have a very good training process. One of our partners is going to be doing it pretty soon, which is exciting. So I look forward to seeing how that goes, and I think I'm still going to be a bit of a late adopter on it, but hopefully it provides a solution that helps with our patients. One question before we move on. What is your current role for thumb CMC arthrodesis?
I still use it. And I believe for me, it's a young patient. And what does young mean? That's an interesting question.
Younger than
Um,
you?
Younger than me for sure. Likely someone in their 40s or younger. And the discrepancy is really around how much force they're creating using their thumbs, so heavy laborers. Um, and I think it's a really good operation that gets not enough positive credit. So I like the operation as a solution. Um, and I just think it's not a perfect solution, but honest conversation before the surgery, especially about the loss of the ability to put your hand completely flat on the table, yields really good clinical outcomes.
Yeah, I like that. I mean, we use it in some different contexts, sometimes for nerve patients, but I think it's a good surgery. One technical change that I've made based on an article that was published in JHS last year is it's an expensive construct, but I do like a headless compression screw with a neutralization plate. I feel good about the stability and the compression I can get across the arthrodesis site. So I like that. But I'm still early in my experience with it, so we'll see how it goes.
Yeah. I agree with you. I think it does make a difference. It can be tricky to place that screw effectively. It is not a straightforward screw to place, but I do think it makes a difference because it's very hard to achieve compression without that screw.
That's a surgery that I sort of enjoy doing. It's more of a type 2 fun situation, because it's like it's much more finicky and technically tedious to do than the, trapeziectomy and suspension of your choice. But I'm happy when I see them back in the office.
Yeah, and they're happy as well. Although we still have a non-union problem. I don't think it's as high as it used to be, but it's even with newer technologies, it's not a slam dunk that this will heal.
So I'm going to skip over the endoscopic versus open discussion because I think people kind of choose what they choose, and a lot of it depends on where they've trained. But I think these articles just continue to show that you can have good results with both, you can have complications with both. Do what you're comfortable with.
Absolutely. And you mean specifically endoscopic versus open carpal tunnel release.
Yes, thank you.
Um, yes, absolutely. And I agree with not getting in the weeds on that. And then they pivot to a topic we've covered previously as well, is using carpal tunnel surgery and biopsy to help confirm an early diagnosis of amyloid, which really there were a lot of articles in the last few years about this.
Yeah, so what's your current use of that? Because when we had our the fantastic resident Carson on service recently, I asked her like help guide me. So she pulled up open evidence, and because I feel like I haven't jumped onto that yet, but I'm starting to now. And I think probably based on some of these articles that were cited here, if men over the age of 50 with bilateral carpal tunnel syndrome and women over the age of 60 with bilateral carpal tunnel, for them, I'm actually doing a biopsy now. Haven't found any that have come back positive, but clearly there may be a role for this.
Yes, and I've had a couple of positives, and I would add if it's carpal tunnel with multiple trigger fingers, that may be a relative indication as well. Um, I think it makes sense. Do I think we have to do it? No, I don't think we have to do it, but I do think it makes sense. Um, in this
How
population.
much tissue do you take?
Um, Not a lot slash the right amount. I don't know how much do you take.
That was the follow-up prompt to open evidence was how much to take, and there's no obvious answer. I guess enough to get the pathologist something to look at, but not too much.
Yeah.
Goldilocks, so to say.
Um, and the last thing on carpal tunnel was the article which said that even for CRPS type 1, open carpal tunnel release can really help patients. We had published many, many years ago about the role of nerve decompression in type 2, and this is taking it to a whole nother level. So something to think about. You got to be careful with CRPS type 1 not to make patients worse with any intervention, but I like this conceptually.
Yeah, and that was the article summarizing Paco del Pinal's experience, which clearly, he's thought a lot about this condition and is starting to share his experience, which I think is helpful. So, I think that for me, the next article, set of articles talks about cubital tunnel syndrome. I don't know if I'm struggling so much with getting to a diagnosis of cubital tunnel syndrome. I think there's just a lot of variability in outcomes with treatment of cubital tunnel syndrome.
I think that's well said. You have to think about the diagnosis in different age populations who may present somewhat differently, but I don't think it's typically a diagnostic dilemma, although subtle cases may be harder to make the diagnosis for.
Yeah, I think that's appropriately stated. I mean, so, these articles mainly focused on severity of compression based on nerve studies and ultrasound, which Warren Hammond had a nice contribution for that. I think for me, I still appreciate the role of ultrasound combined and complementing the nerve studies because I think you can learn different things from each study.
Yeah, and this is obviously building on the CTS6, and that was a major contribution. And I think trying to create an analogous score for cubital tunnel, I get it, and I think there could be some benefit there. But as opposed to carpal tunnel, the specifics of nerve study findings actually drive my surgical decision making in a different way than the specifics of a carpal tunnel nerve study might drive my decision making. Meaning, I'm more sensitive to pushing for surgery when there are static changes in the nerve study for cubital tunnel. And I'm less concerned for carpal tunnel, which I believe is a patient driven decision. And less ramifications for delay in surgery. I hope that what I said makes sense, and I'm curious if you agree.
Yeah, I agree with that. I mean, I think that we just carpal tunnel release is a much more predictable outcome. And you know the different stages patients are at, whether they're somebody who's just, they've got a nerve that is waking them up at night, has tried conservative measures, they don't have any advanced findings on their clinical exam or their nerve study. You know how that patient's going to do. That's your sweet spot. But you know the patient who waits a long time and doesn't realize they've lost all of their thenar musculature. Different conversations, and you kind of know what that outcome's going to be. You're putting out the fire, you're stopping it from getting worse, perhaps saving whatever they have. But they've also learned over time to accommodate, because I think you can accommodate for a median nerve deficit for thenar loss much more than you can accommodate for an ulnar nerve deficit. So that's a much more devastating condition to deal with. And it's just like carpal tunnel release, predictable. Cubital tunnel surgery, I think it can be all over the map. So I think that's where the prognosticator is going to be more important than getting to a diagnosis. So I'm still going to get nerve studies for patients with cubital tunnel. I don't always get it for carpal tunnel. I largely rely on the CTS6.
Yeah, I think that's well said, and I agree. I agree completely with that. Um, our next section is on distal radius fractures. It's a relatively robust section capturing things like the role of bridge plating, the role of um, treatment of volar ulnar corner, radial styloid, dorsal ulnar corner fractures. I think there's a potpourri of specific techniques. Anything you want to highlight?
I think that getting fixation of that dorsal ulnar corner, what I deem the fragment of Brogan, is very helpful. I think that I look for that fragment now much more than I used to because I think of our conversations in conference and seeing these papers that come out. But yes, if you can get fixation into that piece, I think you're going to be much better off if that piece is of substantial size. But other than that, I mean, I think that the timing article they point out here is interesting. I had never thought about whether you needed to get to closed distal radius fractures within 24 hours. Usually it doesn't have a role for me in my practice. Do you think it makes a difference in terms of timing?
I have not seen that personally. I do think this article is interesting. The other article, which addressed the DART study looking at the role of surgical intervention for substantially displaced intra-articular distal radius fractures in patients over age 65. And the study reported a 1 year outcome without demonstrating non-inferiority of casting compared to surgical fixation.
I love that double
Did you
negative.
did you
I had to read
follow?
that sentence like 18 times.
You and me both. You and me both. But I think the bottom line is I still have a hard time. There are over 65 patients that are young, and there are over 65 patients that are old. And understanding the degree of displacement matters a lot. And I think we can be nihilistic in our approach to some patients and do no harm. In other patients, I think we need to realign the anatomy for ideal outcomes. I still believe that, but I appreciate the advancements in the data.
Yeah, I agree. I'm kind of hoping that we can stop studying this. So much funding is going to this that I feel like the literature finally has reached a spot where we have a good sense of what to do. But I understand that obviously this research was probably going on 10 years ago and is now being published. And
Yes,
kudos to the
absolutely.
authors for doing it. It's a lot of work, and RCT is a lot of work, no matter how big or how small it is.
Yeah, not easy. And again, yeah, much respect and appreciation for carrying out research like this.
So, next section is on wrist arthritis. When are you thinking right now that you're going to send somebody to Dr. Boyer for consultation for a total wrist arthroplasty?
Yeah, great question. I tend to, in somewhat lower demand patients that have notable arthritis, especially when I just worry that a PRC might not be a great solution. And, patients sometimes come to me with that question. And I think sending to Dr. Boyer, who is our designee for arthroplasty of the wrist, I don't think it's ever a bad idea. I think we have to be careful about overusing the option in younger patients. What about you?
Yeah, I think that's fair. Again, like just like the conversation about MFTs, I mean, I think that our local expert can have a better conversation with the patient about options and may say, all right, that's not a great candidate, or that is. but I just can't have that conversation because I don't do the surgery and I don't see the patients in follow up. I found it interesting. I mean, there's a lot of articles in here talking about, kind of promising long-term outcomes, but there's still concerns for revisions. Implant design is continuing to improve and still struggles with fixation in the metacarpals. It's clearly not the bone stock you would have in a shoulder, knee, or a hip. And then lastly, they touch on conversions of arthrodesis to arthroplasty, which I think is interesting. Not sure I have many patients who would ever want to sign up for that, but it is good to know that that is an option.
Yes, and that's not a new concept, but this is a bigger study of 12 patients. I have many concerns about that, but I guess for certain patients, perhaps it's the right option.
I'm glad we have a local expert.
That's right. And now the highlight of this article for you is the peripheral nerve section, led off by brachial plexus injuries.
Yeah, so Eric and Nina, thanks for citing our article about disagreements and variability in recommendations. It was this was interesting because we had these as part of our study group. We would do these meetings, and I try to get some kind of academic output from each meeting we get together in. So I just showed a bunch of cases that were from our study to this group of surgeons, and they gave their recommendations. And just like you said for TFCC, the recommendations were all over the map. We understood what the injury was. We knew it was a bad one, but the recommendations varied. So that was a nice article to highlight. So thank you for doing that. I think that the long and short of this section is that as we try to endeavor to restore function, I think elbow flexion probably is a priority over shoulder. And I think some of that's biased by the fact that we're better at getting elbow flexion than we are at getting shoulder function. And then if you're going to do a free functioning muscle transfer, two is better than one apparently, but I don't think any patient of ours is ever signing up for two. And then if you're looking at your neurotizer, spinal accessories is a better neurotizer than the than intercostals than I was shown by Alex Shin and the Mayo group. So yeah, I think that for us, the other article that we wrote in here that was kindly highlighted was talking about just how much pain plays a role. There's a lot of pain interference, that concept of pain getting in the way of your life that we found in our multi-center group. And then that one article we also looked at was, satisfaction with appearance. I think that there's a lot of stigma that comes with this injury, and patients are very self-conscious of that, and our group demonstrated that.
Yeah, yeah, good section. I skipped it, so thanks for highlighting it for me just now.
It was
Um,
right after the ped section that didn't exist.
that's right. Um, there's a short section on finger fractures, which really just highlights that intramedullary fixation remains of interest. I think many of us accept that for metacarpals, it's really a great option. I think its role in the treatment of phalanx fractures is a little more debatable, but certainly worth considering. And then they close with Dupuytren's disease, highlighting a study which showed that collagenase outperformed at 2 years both needle fasciotomy. I'm sorry, let me start over. And they closed with Dupuytren's disease, which showed a recent randomized control trial examining needle fasciotomy, collagenase, and limited fasciectomy, i.e., open surgery. And they found the 2 year rate of success was highest in the surgery group at about 80%, and lower in the other two groups at about 65% for collagenase and 50% for needle fasciotomy. So it's interesting. I think a lot of hand surgeons are sort of locked in on their preferred techniques, but collagenase clearly has a role, not in my personal practice, but clearly has a role for some providers.
Yeah, and I think this is pretty similar to the study to the results published by Marco Rizzo a few years ago. I don't think that was a prospective randomized trial, so kudos to these authors for doing that. Um, yeah, I think you're right. I think people are kind of locked into what they do. I do find it interesting. I've not found many studies that demonstrate superiority of collagenase to justify the additional cost and potential greater complication profile. So I still think for me, a needle is my non-operative method of choice in the right patient.
Yes. And, it's interesting that patients don't seem to mind coming back for occasional needle procedures. Insurance companies don't mind because it's the least expensive of all the options by a long shot. And so it's just interesting when patients come back and request the same thing again, even if I may push a little bit for a open fasciectomy for a longer durability of results. But this has to be both physician and patient driven. And we do need the data, and I hope the authors carry this out at 5 years and beyond, because that'll be even more telling.
There is one insurance company that minds needle laparotomy. That is our friends over at United Healthcare. So we can't
It's
do that.
fascinating.
I don't know how it is in other places, but we at Washington University can't do a needle lap in the office if the patient is insured by United, which is frustrating because I have United. So if I ever need a needle, I have to go to the OR apparently. But I
Yeah.
did to close this out with an anecdote. I saw a patient yesterday in clinic, and we were moving pretty quickly. Actually, I had a schedule in clinic, which was cool. And so she had dupes and was asking about options. And I brought up a needle and actually said, I don't know if we can do it today just because we have to do insurance authorization, et cetera. But she was also going to get scheduled for some other test or procedure. So I was like, oh, Hannah's going to come in and get you squared away. And, we'll find another date for the needle. And I walk out and I ask Hannah, hey, what's the current status of like authorization, et cetera? And she's like, well, what kind of insurance does the patient have? Oh, not United, authorized. So we went ahead and patient wanted it done that day. So we went ahead and did it right away.
And there's nothing quite so satisfying for a patient who's had a long-standing problem like Dupuytren's, and if you can provide day of service intervention with a great result, which, as we know, sometimes happens, doesn't always happen with a needle procedure, it's really great for everyone.
Yeah. So that was a fun day in clinic, and this was a fun session. Thanks for summarizing what's new in hand surgery, and shout out again to Erica and Nina for their great work in this article.
Absolutely. Have a great day.
You too.